Hello and welcome to Health Talk. I'm your host, Angela Baracco Eddy. With me tonight, I have several guests. Dr. Roger Orth is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. And we have two special guests with us tonight to cover our topic. Tonight, we also have Georgia Smith, who is the Business Office Manager at Gastroenterology Associates, and we have Karen Taylor, who is the Assistant Business Office Manager. And they will be here to help us discuss tonight's topic, which is Medicare for All. It should be something that's of interest to everyone because, as Dr. Orth was saying before the program, it's going to affect everyone. So everything that we talk about tonight should be very interesting, and we're going to get into some real details. We are not going to take calls on the air for the first portion of the show, but if you have a question on this topic, feel free to call in anyway, and someone will answer the phone and they can get your question and they'll bring them to us during our first break. So feel free to call us with those questions or comments. It's going to be an interesting program tonight, I have no doubt. Again, Dr. Orth, I'll kind of kick it to you and let you get started with it. There's so much to discuss on this topic. I don't know how we're going to fit it all in an hour.
I don't think we'll fit it all in, but I just thought it would be interesting if we had a chance to have an open dialogue about some of the catchphrases that you hear in the news. And Medicare for All, I see as a catchphrase that, what does it mean? And so as a practitioner, which is actually an interesting point of view from the standpoint as a person who actually sees patients, real live patients, has done so for years, you think, well, how would that affect this guy? Well, also, since I'm as old as I am, then I really don't have anything to lose, do I, by saying something? Because those of you who know my shows know that I often talk about things what I feel is important, and we'll be referencing some of those older shows. But I want to especially thank my special guests here, and I have Georgia Smith, my very special friend. I'll come back to her background, and Karen Taylor, my concurrent special friend, because the entire healthcare system of delivery of probably 75 or 80% of all gastroenterology at multiple locations is actually predicated on these two individuals and their incredibly wizard team. Now, what do they do? Georgia, this special one here, I will remind you all that it was the July 4th weekend of 1984 that I came to Pensacola to embark on a career that was kind of different for me because I had always been in school. I was in school 32 years. I had to finally get a job, and I got here. And then when I was working, I found out it was fun. After a while, it was interesting, though, because I had my little mother helping me with some of the issues. Now, some of you may remember the show with my mother, and I'll get back to her in a little bit, how she's doing. But she's watching this, I hope, tonight. But in any event, my mother in 1984 had worked in the insurance industry, and I made the surprise finding that even though I did something, sometimes people didn't want to pay you. So she was using the accounts, and since she knew about insurance, she was helping in the beginning because it was a small practice, but also we really just had Dr. Haynes, Orth, and Smith, and we didn't have a billing office. We didn't need a billing office because if we said we did it, they paid for it. And the insurance companies, in this case, we didn't have that many insurance companies that much, but if we had Medicare, we would send them a bill, and then they would send us back whatever we billed. And my mom, after a couple months of that, said, you know, you really ought to look at how the system works because Dr. Haynes is always busy guy, and he was using the med tech to do secondaries. What is a secondary? That's when you bill the co-insurance. But the med tech was always too busy herself because she was putting people in the rooms, and she was supposed to be billing stuff. That was the secondaries. Well, then my mom found a drawers of unfiled claims that were from Dr. Haynes and Dr. Smith and myself. So she says, this is ridiculous. Your whole office is a mess. And she's quite the organizer. And so she said, you should find a real person. Who did she find? In 1984, what month?
April.
April of 1984 or 85 then?
86, actually.
86.
You came before
So
me.
I came in 84. I built up a certain amount of inertia, etc. But in April then of 86, what does she do? She does what any good corporate raider does. She stole Georgia out of the Sacred Heart billing office. and in comes Georgia, who's never worked in a private practice mode. Is that correct?
Correct.
And son of a gun, she was pretty darn useful because we actually started to get paid for some of those things that we filed for. And things were changing back then. But how do you remember those early days of working with us?
It was easy.
It was easy. Why was it easy, Georgia?
You did a procedure, an office visit, we submitted a claim, and we got paid.
Because
generally, 100% of your charge. You never had to file anything secondary.
Because the
with Medicare.
System trusted us.
Yes.
The system trusted doctors. And that's part of the theme of my show tonight. Are you going to always want to look at layers and layers of things that don't have trust? Because it's important to look, where is the person that's actually delivering your care? Those drawers filled with thank you notes that I have came because I could stay here. I could keep working. And it's Georgia, and then ultimately Karen, who was in 1984 working for a West Florida hospital. And son of a gun, ultimately she gets swept into the tour. And we have a whole crew now. And we have to have a whole crew now because the system was broken. And part of my discussion tonight is that, yes, the system is broken, but those of you who know much about digestion, so some people didn't like my initial title, which was Medicare for All, Ulcers for All. But then I thought, well, what is a Boerhaave syndrome? Since it was a digestive talk. And a Boerhaave syndrome is when a patient eats something, it's so big, it can't swallow, and then ultimately they retch and they rip open the esophagus and they can die. Do not swallow a system that cannot be swallowed unless you know that you could die. And so, in the waning days of my time, I thought, let's get some details of how did things get out of hand in medicine, so much so that we want a group of people to take over who are actuarial bureaucrats and have never looked the patient in the eye and say, you have cancer, or I can do this for you, or we will send you this. So, Georgia, originally it was pretty easy. Is that right?
It was.
And how did that work out? You would just send something off and lo and behold, we got a paycheck and that was that?
That was pretty much it. Some of the carriers we had to file secondaries on, but not many. It was back in the day when you submitted the claim to the employer, not the insurance carrier.
Right.
The claim was mailed to Gayfer, 7-Eleven, Monsanto, St. Regis, and their insurance office processed the claims a lot of times.
Yeah, and I remember Monsanto was the biggest employer at the time, other than, of course, the Navy. But Monsanto, as a big employer, they ultimately got Dr. Collier, who was the primary doctor for the group, but he would call us all the time and say, would you do something? And of course, in those days, standard colonoscopy was not part of the deal. We did a lot of office visits because it was not one of those health risk things, even though it was so logical that certain people should have a study done. And in those days also, there was a lot more inpatient work. There was inpatients all the time because this is the way hospitals had been run. But as it evolved, then it got down to a point where you couldn't actually work it out with the system because the system started to question how that was being done. And if you look at the history of Medicare, so Medicare starts as an act in 1965, 64, somewhere in there. There really had been an idea from FDR, but he didn't think that they could swallow a national system, especially in the setting of first the Depression and the World War. So he decided that fight 2 world wars and two international battles and revamp the system, but he didn't want to pursue that. And Mr. Kennedy, when he was the president, for a short time he thought about having Medicare for all, but he got involved with this guy in Cuba, Castro, and he ended up disappearing. And so we lost him. But then there was this flux, and then Lyndon Johnson decides, let's get this through because of a polarizing candidate that had led the charge against him, which I think was Mr. Goldwater, if you remember your history. Then he was such a polarizing candidate, they had a group of people who said, well, let's just take over lots of social programs, including Medicare for All. And so there's a certain interesting template as history is a rhythm, isn't it?
Mm-hmm.
So as we go back to Medicare for All, it's really an extension of Medicare. And I want to talk about some of the problems we see with Medicare today. Because if you want what we see in Medicare today, wait till you get it for all. Because it is become more of an issue. And part of the problem is to divest the business end of medicine from people who look you in the eye and actually take care of you. And I think that the layers have come on over the years, hasn't it?
Mm-hmm.
Which part of the layers started first?
Well, I think capitation got us first, but that, I don't believe that was Medicare too much. Then it came into all the managed care plans.
Well, let's go back to capitation then. We have capitation as a something on the horizon, and some years ago I went to a Medicare a coding conference, even though I was a digestive specialist. But at the time we were dealing with HMO issues, and the HMO issues became obviously that they have these interesting schemes of how they're going to pay a physician over the years. And one of the scheme was not that you deliver a service, but you will get paid for the population. And so this member's payment per member per month. And we had this. So at some point I went off to go learn about the fine tuning. And I came back from a Polly Dunlap course. You remember her?
Mm-hmm.
Polly did all these really high-end, interesting billing courses. And I went to South Florida and identified that it was dog eat dog down there. Every gastroenterologist was their own enemy. And so I came back and I said, I don't think we can actually survive, and I don't want to work for somebody else. We need to figure out how to deal with that particular HMO issue of payment per member per month. And so ultimately we decided we should own the means of production. And that's when we did a merger with our colleagues who are now the former Baptist people, but in fact are definitely our Sacred Heart people, and in fact multiple other hospitals, Dr. Fry and Dr. Carty, and then ultimately the others too. So that merger was generated by a payment scheme. And so that's where that merger came from historically. And in fact, the only reason I'm actually still in practice has to do with that merger. Because as the time goes on, it's true, I have a large practice. I've had a very large practice, a very wonderful emotional relationship and friend relationship with a lot of patients, and happy to deliver care relationship. But as the time rolled on, it turns out I needed the skill set of a Karen and a Georgia. And so the capitation was really HMO. And that was a model that actually failed on a grand scale. And so it disappeared. And so then we had other system come in. What was that one?
I'm thinking about the Medicare Advantage plans.
I think the Medicare Advantage plans, is that a Medicare Part C?
I believe so.
So Medicare Part C actually starts to kick in small at first in the later 80s, I think, and then early 90s. But then the people running the Medicare Advantage plan figured out there was a way to do this in a different way. And so let's go over Medicare for a minute. Because Medicare is really what everyone wants for all, isn't it? So because it's good for them, it must be good for me. And so we're going to talk a few minutes about, there's a Part A, that's the hospital part. It was always there. And actually the hospital costs on a basis of a per capita basis has not exploded that much in the last 20 years, as much as some of the other services have. But yes, it's expensive to go to the hospital, but if you look at it over the whole population or the gross domestic product, that part hasn't exploded. The physician cost did go up. That's Medicare Part B. And that's what these two are, specialists on Medicare B, but they also are quite the experts on Part C, D, and A, as well as Medicaid. And how many insurances we have? Maybe 70, 80?
There's so many umbrella companies out there, it just multiplies.
Yeah, so the insurance agencies that a lot of the politicians talk about that we're going to save some money with that, I actually agree that there is some money to be saved here. But I think that you can save the system without killing it. Don't swallow this one unless you're sure you can swallow it. This is what I always tell my heron when he comes on the dock and I give him whole fish. I as a judge on high and I give him live fish, I always am careful not to give him one that's too big because he might swallow it and die, and that would be my best friend from an animal standpoint.
Which is a great place for us to take a quick break. I hate to interrupt right there, but we are going to take a quick break. We have a lot more to cover, so please stay with us. We'll be right back with more Health Talk.
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Has anyone ever said, "You are the picture of health"? You look healthy, you feel fine, but that may not be the full picture. Colorectal cancer is the second leading cancer killer of men and women over 50. It doesn't always cause symptoms, but it can be prevented. Screening can find precancerous polyps so they can be removed before they turn into cancer. Get screened. Make sure you are the picture of health.
And welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight are our 3 very special guests, Dr. Roger Orth, who is a board-certified gastroenterologist with Gastroenterology Associates of Pensacola. We also have Georgia Smith, who is the Business Office Manager at Gastroenterology Associates, and Karen Taylor, who is the Assistant Business Office Manager at Gastroenterology Associates. So, all of them are going to continue discussing our topic for this evening, which is Medicare for All. And before we go too much farther into this, Dr. Orth, could you or Karen, Georgia, one of you, kind of give us an overview of the basics of Medicare? Who's eligible? Who can receive Medicare services?
Well, the first Medicare recipients in the country was actually Mr. and Mrs. Truman. And because they were retired and they were without a job. And so they became the first recipients. And it was originally designed to fulfill the needs of retirees, which is above 65. And so when it started, those above 65 had a certain life expectancy, and we didn't want them going because they had served our country, they had made us what we were, because they were hard workers, these people, and at the end of the day, it was above 65. It didn't say you couldn't live to 100, but above 65 at the time, you had an actuarial table, which has changed now for your life expectancy. Ultimately, the first permutations on Medicare occurred that in addition to it, and you would have add-ons. And I can remember when the add-on was dialysis. So dialysis is expensive. So it became a notion that we will have everything to do with dialysis covered if you will put it in Medicare, whatever your age is. Because that was a risk everyone would have, but it was felt that we will use the Medicare Trust Fund, which is paid by a specific set of taxes. And that would, even if they were not 65, they will cover that. Then ultimately we had more disabilities. And so we have a series of disabilities. And over the last 10 or 15 years, the explosion in the number of people with disabilities on Medicare, those people under 65, has been remarkable. And that group with the disabilities, in fact, have a very high consumption of services. So we have that group. There are also some very niche groups like the Lou Gehrig's disease, because probably some senator or somebody knew somebody with Lou Gehrig's disease and knew that was a difficult problem. And then there's black lung, and there was railroad kind of things, little niche things that you get as part of you gerrymander. But that was the main core of the Medicare. And really Medicare is not the provider. They're using different insurances, and so they decided to use different insurance products to deliver it. And this is where our problem comes from, because we're still doing the same thing we ever did, which was we see patients, we figure out what's wrong with them, we tell them how to get treated. But now there's more people getting covered. People suddenly, in gastroenterology at least, it becomes a standard for us to do certain things. And it turns out minimally invasive surgery explodes. And we are minimally invasive surgeons. And when I went into med school and even residency, there wasn't any endoscopy. When I was in fellowship, it was just starting. And when I came, it exploded. There was all over the country. The ability to do surgeries with a scope completely changed. And the feeding tubes or the common duct stones and all those other lectures we've given, because healthcare delivery became as little as possible using open surgeries. Then we started having different plans. And one of the plans that became as to how to do it, we have two types of Medicare. One, we are calling red, white, and blue.
The traditional.
The official, traditional, right, Karen?
Yep.
Red,
Traditional.
white, and blue, because we are Americans. However, the red, white, and blue would give you a service, but then they decide to play around with it and figure out how could they save money on it. And that became part of the C plans, right?
Right, Medicare Advantage.
How does that work?
Well, it works quite well for a lot of individuals. You really have to select the plan that you benefit the most from as an individual. Each of the Medicare Advantage plans have different benefits sometimes, and so whatever needs you have is really what you need to go by on selecting your Medicare Advantage plan. Instead of having co-insurance amounts, your 20% co-insurance amounts, you have a copay usually. So every office visit is a set fee, no surprises. Your 20% is out. It's a set fee, usually $20, sometimes $40. At the facility, instead of paying 20% of your facility fee for your procedure, it again is set at a set fee, $150 copay. So it has its advantages there, but also there's a lot of red tape that we as providers have to go through in order to be able to deliver that same care to you that we deliver to the traditional Medicare patient. Authorizations for a lot of them, they get to tell us whether or not you meet medical necessity. Dr. Orth could say, hey, this patient needs it, but it's really someone on the other end deciding whether or not they're going to approve it and pay for it. So
let's look at a timeline then. Can you capture this by chance? Because I've got my little iPad here. I was a little tardy. Home in on that. Can you zoom in on it all? Keep coming. This is Medicare Parts A, B, C, and D by year. And just so you all see it, you can see this particular year is interesting because this year is 1996 or 1997, and that's when the C's take over. And they really change a lot. So we end up having this sort of explosion in the different types of permutations of the C's.
And why would someone not be eligible for traditional but need one of the Advantage plans?
They were always eligible for traditional, but the traditional has a 20% copay. It's the 20% copay that parlays it into a multi-zillion-dollar industry. The fact that somebody would have some skin in the game, would actually have to pay part of their care.
Wow.
That's the gamut. This entire problem is happening for the 20% copay. And so a lot of the expenses or hassles that we have in processing a claim is the 20% copay. If it was, isn't that right? So if it was a standard charge, then they would just pay out of pocket. And in the day, before things accelerated in pricing, and in a combination of reasons why things went up, but that insurance gamut is how the different Advantage plans evolved. And there's different kinds of Advantage plans, right?
Just about every carrier has an Advantage plan. You've got your Aetna, you've got United.
Blue Crosses.
Blue Crosses have their plan, Cigna. Just about every carrier has a Medicare Advantage plan now.
And some of them have more than one.
Different options.
Yeah, different options. They have more than one. And this is where it gets confusing, especially if you're the little old lady who might get sick someday, or you're going to potentially get sick. You're trying to figure this out. But how does it work out for us when it comes to dealing with the Advantage plans of different types?
Us as a practice.
Us as a practice, not me.
Well, the claims don't get paid near as quick or as easy as traditional Medicare. So there's more follow-up, more phone calls, more multiple billings to the carriers, submitting records to back up the claim that they approved the service for. You basically fight more for your money. They're not all like that, but they're not as easy as traditional Medicare getting your payment from.
So we would file claims, and suddenly we're filing claims, and then we have to do the secondary set of claims, and then they ultimately would come up with that. It's interesting because the other traditional insurances often then ultimately decided that Medicare is an interesting template. But it's an interesting template because that's part of the problem. Medicare has always wanted to be the low bid because they're government, and everything that's low bid must be better. But don't always say that you get what you pay for, but low bid means that when, let's say it's a hospital, the hospital, if they're getting their Medicare, 80% of their costs are covered, but the different carriers, the different insurances, the Blue Cross or whatever, they're actually covering 150%. And so it's an interesting game because you have all these different insurance types, and you're always probing the system, and no one can ever talk about this because we don't really know exactly how things are. But if we submit a claim and we get a bill back or a check back, we find out what they're paying, and it becomes a commodity, and medicine becomes a commodity. And that's part of the problem, is that medicine has become a bit of a commodity, hasn't it? And it becomes such a big commodity that it's affecting a lot of money. So much money. Here's another picture. How much picture do I have? I only have 2 pictures because I was tardy on sitting on my slides. But I thought this was interesting because remember, with Medicare for All, we have to fit it into our federal government plan because they're going to swallow this. Don't choke on it, though, please, Uncle Sam. But this is Medicare as a percentage of the federal debt, of the federal spending. Can you home in on that? Now, great. Even though we have green screens here, I don't have a green screen. That's great. So this is the one that's Medicare. So currently, Medicare alone is accounting for 15% of the federal budget. In the next 8 to 10 years, it's supposed to go to 18%. And unfettered, it would actually be at 25%. This is just for the care of this grouping of people. So clearly, it's a broken system because Medicare will soon outpace, let's say, defense spending. And there's a lot of interesting parts of just this one little pie. It's hard to swallow a whole pie. But the piece of the pie that keeps getting bigger is this one. This is 8% right now. 8% of every dollar that the government spends is for its debt. So it's important to realize that there's a reason why the government may want to have low interest rates and parlay the interest rates lower because they're having to pay interest on stuff because they actually owe a lot of money. In the last 10 or 15 years, it's been astronomical. It's caused the changes in several presidencies. It may cause the change in more presidencies. But at the end of the day, you're supposed to either pay it back or inflate it out of the system. And I'm afraid that part of the problem is that they may have a plan to inflate it out of the system. My little mother is just selling her house that she and my dad built in 1952 for $10,000. I think she's going to get like $250,000, let's say. So it's a very modest house. We had one bathroom, and the sink leaks, and she really should move to the apartment. But what happened? When do you remember that you could buy a car for $3,000?
Right.
But there's one approach is to inflate it out of the system, which means that we end up having a problem, don't we? Because it's built into the equation that you can't let this thing go unabated.
Right. And I'm going to have to interrupt for just 1 minute because we have to take another quick break. But we will get back. We have a lot more to discuss. Please stay with us. We'll be back in just 1 minute with more Health Talk.
It's impossible to replace anybody that you love. She was my great role model, my Grandma Keaton. It was pretty much of a shock for us when she got colon cancer. None of us were prepared for that. Here's the deal, and this is the bottom line here. Colorectal cancer is the second leading cancer killer of men and women over the age of 50. And you know what? This is one that you can prevent. Just get screened, okay? I know how precious life is right now. We can all do this. You can do it, I can do it. If I can do it, you can do it, okay? How's that for a deal?
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. We are talking about so much. We have been talking during the break. We haven't stopped. There's so much to discuss tonight. Our topic is Medicare for All, and we're talking about some of the different things that the Endoscopy Center and Gastroenterology Associates has seen through the years as things have changed with Medicare, with smaller office versus larger office, larger practice, different things like that. And there have been a lot of changes over just really the last 30, 35 years just in their one particular office that we've been discussing. So we did have a call come in. I want to try and get to the call real quick because I think that it's going to be a good segue into some of the other things that we're going to discuss. So hopefully I get the right line. Hello, and thank you for calling. Do you have a question or a comment for Dr. Orth?
I do. I can't believe that y'all are on TV tonight. Hey, I went to my family doctor today. I have this thing where I eat sometimes and I have a hard time swallowing, and my doctor said they will refer me to you and going to refer me to you because for some kind where they go down my throat and then they can open up that area. But I'm curious if you have any idea. I'm on Medicare, and I have Medicare Advantage. Kind of what the price of that might cost approximately?
We're more than happy to answer that because that's really why we're here to talk tonight, isn't it? Mm-hmm. And thank you for calling that in. She's going to answer that in several different formats.
Absolutely. So thank you. Thank you very much for calling.
And we're going to discuss your specifics here because you have trouble swallowing. Can she still hear me?
Yes, I think so.
Yeah, just when I'm eating and it'll get caught.
Right, so
you can do something down in there.
And so obviously this is something we do every day. It's very easy for us, and we're lucky to have a team of people who can do that. But we can look in there, we can fix that. we can make sure that it's just a benign problem. And sometimes it's not a benign problem. You can't wait till you actually have the piece of meat stuck, you retch and you rip your esophagus open, because that's really the end point, isn't it? It's similar to the country swallowing Medicare for all. But if you are having a problem swallowing, we do a minimally invasive procedure. So how does Medicare cover that, Georgia?
We have different fee schedule allowables for each of the plans, and she mentioned she had a Medicare Advantage plan, so we have those allowables as well. So we can give you our best estimate on what the procedure will be.
I know it's just, I understand it's just an estimate. It's just kind of ballpark, just to get an idea.
Well, we won't, the part we don't know is the exact procedure that Dr. Orth would do
Let's
to
say it's upper
dilate.
with Dill.
Upper with Dill. And so you've got different methods of dilation, so it really depends which of the three methods he utilizes to dilate it, so that changes the price as well. But we could get as close as possible. There would be the doctor fee, the anesthesia fee, the facility fee, and then if there's any biopsies, there'd be a pathology fee. But I don't have the price listing with me right now, but you would be very limited on your responsibility because you have set copays. So we will know up front what your facility copay will be, and some of them are $150 as opposed to, and then the doctor would have his set fee. A lot of times that's $50, but without knowing your specific replacement plan and having their allowables right here in front of me, I can't give you the specifics over the phone. But you're welcome to call the office in the morning and ask for Georgia, and I'll personally speak with you regarding your estimate.
Okay, that's cool.
So it sounds like most of the Medicare Advantage plans would have a copay. Depends on which one that you bought.
It's so $200, $300.
Well, less than that for you. Probably 50 to 150.
Typically.
But I'm going to use you as a jumping point for how this works. So thank you for calling, if you don't mind.
Thank you very much. We appreciate your call, and do call the Endoscopy Center tomorrow. The number is on the screen throughout the program. Ask for Georgia, and she will absolutely.
Georgia's the boss, so really, if it weren't for her, I wouldn't have a job. But let me cover this briefly.
She will take good care of you. Thank you so much.
Thank you for calling. So what we did is when we melded this practice together, we built a facility that delivers quality care. In fact, it's the only top-rated facility for ambulatory surgery in the region. And we actually offer these same surgical services that my partners and I also offer at the hospital or hospitals. But the trick here is this is part of the reason why things are so expensive. The fact is that the net cost on all of those things that you mentioned, whether it's the procedure fee or the biopsy fee, whatever, the cost is going to be different if you go to a hospital than if you go to the facility. Different by a factor of 4 or 5. And this is where part of the reason why, if as a practitioner, if I were to want, and in fact I remember soliciting calls for Mrs. Clinton, that maybe when they were going to do healthcare reform, they'd like to have actual practitioners tell them what you might want to do, but they never called me either. And those of you who remember the show I did for Mr. Trump and I did a show for Mr. Obama, they never called me either. But the fact that it's 4 times more money at a hospital for the exact same procedure, this is where the gap comes from. This is the problem. And so, yes, we can deliver you the care, it's identical care, but I'm not allowed by law to advertise that. No, I'm not actually advertising right now. It's not a print ad, but I am actually telling you what is part of the cost. If you want to fix that system, you will straighten out how things are billed. Places that can line item something, they charge for every single moment. This is a lot different than a place that gets a flat fee. It is also interesting, Georgia picked up our charges for, let's say this lady asked for endoscopy, so I'm going to tell you what the physician payment was and is. Because Georgia is so organized. And when I made her sit down preparing for this evening, because I really owe her for this, but we sat down, and son of a gun, if she didn't pull out what the standard payment charges were in 1986 for that procedure, and then all the way up to now. So would you mind telling me how that difference worked out?
Okay. EGD of biopsy back in 1986, you got $325.
So
The
if I submitted EGD with biopsy, they gave us EGD with biopsy. So they gave us whatever we charged in 1986. Is that right?
Correct.
So I got $300 to take a risk on your life and make sure you didn't perforate your esophagus, which, by the way, is a lot cheaper than any of the ways that they did it in 1978 or 82. And so the risk of those guys doing it with their other tubes, this is why flexible endoscopy took over. So in 1990, they cut it down.
No, it went up.
They went up. Oh, I got a pay raise.
Yeah,
1990, this was the peak of being a doctor. This must have been when I got a new car or something, because they went up to $350 instead of $325.
And it continued to go up until about 2000.
Yeah, but it didn't go up that much more. But then they started to revamp the thing. So they decide, well, if they're going to squeeze the system, let's get the providers involved. But they don't actually squeeze out where the problem is, because they drop it down. In 2005, it goes to 161. In 2016, 153. What is it now, Georgia?
147.
For $147, I will save your life from the standpoint if I find out you have a cancer or fix your swallowing. It's not that big a deal, because we do it all day. It's entertaining. And if I retire, I actually have to do yard work all day. And that's why I'm here, because I like human video games. But in reality, we get 1/3 or so. And of course, there has been a cost of living change, but that's okay. But how hard is it to get the money today than it was in 1986?
Much harder.
How do you
Much
think,
harder.
Karen?
A lot, especially if it's an Advantage plan.
Some of the Advantage plans are a lot more difficult for us,
Yes,
aren't
are.
they?
They require authorization. We have to get permission to get this done. Perfect example, EGD with biopsy. If that patient comes in and we get this authorized, we're thinking that we're going to do a biopsy. You don't know you're going to do a biopsy till you get in there and see. But we just say we get the regular EGD authorized with the CPT code. Well, if you decide to do a biopsy, our authorization has a different CPT code on it. So when we send in our bill, guess what? They deny that because we have a different CPT code.
So you're going through this process.
So we
now
have
let's
to-
go down this rickety road. Sometimes you have to submit it, then you resubmit it, and then you have to send in what?
An appeal. You have to
We
appeal
have
it
to
all.
appeal. And sometimes it's too much trouble, and we collect these appeals with some of the Advantage plans, and we then one of the worst plans I think is Medicaid, but they are even probably a lower number. Is that
Oh
right?
yeah.
Oh, much
How
less.
much is Medicaid for that?
I think it's $91.
$90. So Medicaid, by the way, the same group of people they're rolling into Medicare for all, they're currently paying the system $90. They're paying us $147. They used to pay us $350. But when they roll that in, that's going to be amortized over the population. And that's not to mention that if you have a Blue Cross, we probably get paid more, don't we? So that's the group that you're also rolling in to the amortization of the whole system. But let's take for a minute, because I don't want to run out of time before I get to my real point here.
And we are.
And we're going to run out of time. Why don't they, in this plan, why don't they do it into the only single payer system that's been going on for my entire career? Why don't they just say, well, of course we do the best for the people who served us, whether it was in World War I, and by the way, I've taken care of Spanish-American War vets and World War II vets, and many, many people who were involved with Afghanistan and other vets that really served this country. Why don't we just roll this whole thing into the VA? That must be a good single-payer system. Let them all, everyone in the country, go to the VA, a single payer, high quality. How well does it work if the VA wants to do some billing to us? How does that work out for you?
It's about the worst
The worst case scenario.
case scenario.
We'd rather write off your check and be no charge than deal with the VA, because Tell me about that little guy who had the VA problem you dealt with today.
Yeah. 2 hours researching it and trying to find out how he got into the office, because in July we had a phone call with QTC, which is a contractor that the VA utilizes to schedule veterans that they can't get into their system. They send out and schedule the veterans with private practices. So in July I told them that we no longer participated with their program because of the burdensome paperwork. The paperwork, when I say burdensome, I mean it's pages and pages and pages that the doctor or the provider has to complete all the boxes and spaces and then submit that paperwork to them so they can type up a report and send back to you to sign.
In 24 hours.
In 24 hours. They will not accept our office note. And this gentleman, 80-year-old veteran, was applying for disability benefits. So when I found out he was 80 years old and it was because of disability benefits, I said, oh my gosh, okay, we saw him, we're going to follow this through. So I called the gentleman who was the rep that I spoke with in July.
The rep from the VA.
QTC, their
QTC,
contractor.
a group of bureaucrats who are running the VA's healthcare delivery system, parsing it out to private medicine. How many times have you heard that healthcare in the VA should just be rolled into blue fee-for-service because the vets are not doing well?
Right.
Wait till we all get a handle of this. But what happened then when you talked to the
then
VA rep?
I told him that we both had responsibility to take care of this patient, but that we would be happy to leave him on the schedule, but that we absolutely would not comply with the paperwork that they required us. And so he accepted it. He agreed to leave the patient on the schedule. We called the gentleman today, told him to be sure to be there, and that he agreed to accept our op note, our path report if there's pathology, and our office note, and that they would take care of the burdensome paperwork on their end. So that was a success story, but that was 2 hours out of the day. It was almost canceling the patient, and with this procedure is the only thing that is between him and his VA disability benefit decision. So it was important, to get him in.
But to get his VA benefit, so he wanted to get a disability from, a service connection. But this guy had Medicare.
He had Medicare.
We could have done it with
life.
Medicare with no problem. And because the Medicare charges do not require anything more than our op note and a logical explanation of why we took care of an older guy.
I have to stop for just 1 second. We have to take our last break. I promise I won't do it again.
We're going to run out of time.
We are going to run out of time. It's going so fast.
Unbelievable.
We will be right back with more Health Talk. Stick around. We've got a lot more to discuss.
Our weight, it's with us every day. It's not that we don't try to say goodbye to our excess weight. We do. We exercise, we eat healthier, we try to stay active. But for many of us, it's simply not enough. Well, there's finally a solution. Introducing Orbera, a non-surgical procedure to achieve meaningful long-term weight loss. Orbera is a new non-surgical weight loss procedure that can help you gain the edge and lose the weight. People lost more than 3 times the weight with Orbera than diet and exercise alone. Orbera gives you that edge you need to lose the weight and power a more confident, healthier lifestyle. Orbera is not for those who are pregnant or breastfeeding, have autoimmune or organ disease. Heartburn, stomach discomfort, abdominal pain, and bowel obstruction are rare. Other adverse events include nausea and vomiting. Find out more and see if Orbera is right for you.
El cine nos entretiene, pero esto no es la vida real. Lo que sí es real es que el cáncer colorectal es la segunda causa de muerte por cáncer entre hombres y mujeres. Los pólipos que lo causan pueden detectarse y eliminarse antes de que se convierten en cáncer. Pero tú lo puedes prevenir. Hágase un examen para detectar el cáncer colorectal. Yo lo hice. Podría salvar su vida.
Si usted es mayor de 50 años, hágase el examen de detección.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. I'm going to get right into the discussion because we have so much to cover and we just have a few minutes left. We have a caller who Dr. Orth has spoken with previously, and I want to get to him while we still have a couple of minutes. Hi, do you have a question or a comment for Dr. Orth?
Yeah, hi. I'm a patient of Dr. Orth, and I had a long talk with him, in his office a couple of days ago, and he had asked me to call into the show. I'm an insurance agent in the state of Florida, so we had quite a long discussion.
Yes, absolutely. Dr. Orth.
Well, you're an insurance agent in Florida, and also, do you not sell Medicare products in other states also?
Yes, I do the state of Florida and 40 other states.
And you've been doing this for some years, haven't you?
Yeah, 10 or 15 years. We used to do the Obamacare plans in the state of Florida only. Then we switched to Medicare only because the Obamacare plans were not very profitable to sell and very difficult.
But
So,
as a person who helps real patients get to the end point, which is delivery of care, how do you think it's going with this Medicare for All deal, by the way?
I think the Medicare for All is kind of a bad idea, number one, just because Obamacare was supposed to be the thing that fixed that problem. And obviously Obamacare did not fix it. So
Well,
kind of crazy. So I see it more as the government trying to use Obamacare as a stepping stone into a single payer system. Or
right. So I'm going to go back to my single payer, but I'm going to take a second to, and actually he does sell insurance, and he's a little bit different. Where these girls bill the insurance, he sells the insurance products to that nice lady on the phone, etc. So I
Right.
thought it would be nice to have an additional one, but the girls and I were talking earlier how Obamacare worked out for us. But I will point out to you that Obamacare has actually in many ways increased the working people who are paying insurance, is their payment. There's a lot of people that actually get Obamacare stipends from Obamacare, and up to $700 or $800 in a month or whatever it would be, right?
Sure,
But
absolutely.
a lot of people get a check, but the cost for people's insurance has doubled and tripled for those who do work. Is that right?
Yes, that is
so-
correct. And about 80% of all people who are on the marketplace plans do get a subsidy of some kind.
Right. So in summary then, Obamacare has not only accelerated the cost differential to, and this is actually, wait till the country swallows this across the board, but it also has increased the costs in different markets because it has encouraged mergers. The rate of hospital-based mergers, the rate of hospitals making ACO systems so that they can own every physician in it, we're one of the only independent ones left. And you may be seeing me as I go out the door here, because obviously this is where the crux of the matter is that they're changing and narrowing the focus. And now they're going to just take over the economy.
Right.
So anyway, thank you for calling. I hope your wife had a good birthday.
She did, and I'm sorry I couldn't have joined you, but I'll talk to you soon, I'm sure.
Yeah, maybe we'll do another show sometime. So I just have a few moments left.
Thank you so much for your call.
And
all right,
and
thank you.
You can see I'm a little polarized on this because I have lived this. But I've been wanting to think, what would I do if I should join Dr. Carty by retiring? And I've thought about different choices, and I wanted to go over a couple of choices that I've come up with. One of them, this seems a logical choice, is to have an offshore ship where we will actually be off the federal limit, and I will supply quality health care, and you'll still get a cruise, and it'll pay for itself better than what you're going to get from the other one. So I could have a cruise line. Number two, there's a chance that a guy who's done 100,000 colons, not to mention a lot of other stuff, would be very good at professional video games. Do you realize they're paying $1 million to a kid who is in the 7th grade or something, or high school, and he's playing video games? Is this where the country's going, is video games? Well, I'm good at video games. Let's get a group of us gastroenterologists and have teams, and we could go in against Fortnite. Another one is that I could work over at the airport for the deep cavity searches with my whole team. I could get to the bottom of this. And I had volunteered this to several of my special friends, that I would be more than happy to work for the DOD, because I could have told them, if they had sent those guys in Guantanamo up for a colon, I could have got out with them, where is Osama bin Laden, saved a lot of money, and I could have put in one of my special GPS devices so they could follow those assholes home.
Oh.
But nobody did that. But the last one that I have as my special moment is that I've decided to take my special team to Washington. And I am going to straighten them out. And my team is going to colonoscope the entire House and Senate. Maybe some even higher offices. I'm going to straighten out the little things and tell them, and I'm not needing all the sedation people, and we're going to get this straight once and for all. Because this is a problem for me. It's a problem for you. I may become a consumer of healthcare, and it bothers me. So I have a little song I wanted to play for you, and just because I did not know the words of wisdom that came, because I was enough of a geek that I didn't know music. But if you listen to Mick Jagger, and he's playing back in the day, and he's talking about where are we going? He says something very special here. You can't get what you want. Get what you want. But you can get what you need.
And that is going to have to be our
You can get what you need if you just ask for help from people who really deliver health care. Thank you, girls, for coming.
Thank you all. And thank you for joining us. We've had a great time. We look forward to seeing you next month with more Health Talk.